There's a pressing question, I think, with ibrutinib, that if you reduce the dose, does that decrease the efficacy of the drug? Do you get less BTK occupancy? Do you get sooner resistance? And also variability in how successful dose reductions are in really reducing adverse events. So this study was undertaken using real-world evidence from an EMR to try to get at the question of, if you dose reduce ibrutinib, do you decrease the benefit that patients get in terms of disease control? So since it was like a real-world evidence retrospective study from EMR data extraction, time to next treatment was used as like kind of a surrogate for progression-free survival, which I think is very fair in this setting and more accurately captured with this type of data than progression-free survival. And it was almost 1,200 patients, and looked at patients starting ibrutinib who had a dose reduction or who did not. And what they saw was there was no difference in time to next treatment between those who had a dose reduction and those who did not have a dose reduction, really supporting that if ibrutinib dose needs to be reduced, that it won't decrease the efficacy of the treatment. And I think that's really important. So this does not support global dose reduction for everybody. That's not what the study was looking at. But it should allow physicians to feel very confident in dose reducing ibrutinib if they need to manage adverse events. As part of this, there were 2 measures of adherence that were also examined. It was medication possession ratio and proportion of days covered, both adherence measures, and they were actually numerically higher in the group that had a dose reduction of ibrutinib, which sort of makes sense too if it became more tolerable for them. So I just think this is a nice real-world data set, and kind of pairs with some other clinical trial data sets looking at dose reduction to say that reducing the dose really isn't a huge problem if it needs to be done.